Good afternoon, and welcome to the 2021 Federation of State Medical Boards Health Equity and Medical Regulation Symposium. Today, we will explore how disparities are impacting U.S. healthcare quality and delivery, and why it matters. I'm Dr. Cheryl Walker-McGill, Chair of the FSMB, and I will be your host today. The statistics are clear and compelling. Despite the wonderful advances and promise of American medicine over many decades, healthcare continues to be delivered on an unequal playing field. For years, we have known that patient race and ethnicity are independent variables impacting infant mortality, chronic disease outcomes, and life expectancy in the United States. Many factors contribute to disparities, and there is clear evidence of differences in treatment. In 2002, the Institute of Medicine, now the National Academy of Medicine, published its report on equal justice. The report found that racial and ethnic disparities in healthcare indeed exist, and that many sources, including healthcare systems, healthcare providers, patients, and utilization managers, are contributors. Minorities continue to be underrepresented in the healthcare workforce, and increasingly, there is evidence that minority patients receive substandard care due to racism and implicit bias. One only has to hear the heartbreaking story of Dr. Susan Moore, an African-American physician who died in December of COVID-19, to understand how devastating the issue of health inequity can be. Dr. Moore literally pleaded with her physicians for help as she was denied the care she needed. Many who work in the healthcare system have their own version of Dr. Moore's story to tell, and many have experienced inequitable treatment themselves. All of these issues have been magnified in recent months by extreme racial and social upheaval in the United States, and of course, the ongoing challenges of the pandemic. We are living in a truly difficult time. Tensions are high and communities are in turmoil. In this environment, every sector in the United States has a role to play in seeking to help, including the medical regulatory community. And so we gather today and ask, what can we do to mitigate the impact of racism, implicit bias, and other factors on health equity? What do medical regulators need to understand about this issue? And what needs to change in medical as far as policies and processes in medical licensing, discipline, and regulation? What role can our state medical boards play as the nation seeks positive change? Today, we have assembled some of the nation's leading voices on these topics to help us begin a dialogue on health equity. We are extremely fortunate to have two outstanding keynote speakers today. We will begin with Mr. Marc Morial, the President and CEO of the National Urban League. He will help us understand the core issues of racism and implicit bias that drive health inequity. Mr. Morial will be followed by Dr. Mark McClellan of the Duke Robert J. Margolis Center for Health Policy, and he will focus on the issue in the context of our healthcare system. Many of you may know Dr. McClellan as the former administrator of the Centers for Medicare and Medicaid Services and as the former commissioner of the U.S. Food and Drug Administration. After these presentations, we will move into a panel discussion, which will be moderated by the FSMB's President and CEO, Dr. Hank Chaudhry. And again, we'll be joined by national leaders and members of our own medical regulatory community who will discuss disparities and health equity in the context of medical regulation. We are delighted to welcome Dr. Leonard Weather, a member of the Louisiana State Board of Medical Examiners and the past president of the National Medical Association, Dr. Aletha Maybank, the American Medical Association's Chief Health Equity Officer, and Dr. Diana Currie, a member of the Washington Medical Commission. Our symposium is scheduled for 3 hours, and during the course of the symposium, we will have 2 breaks. Our online audience will have the opportunity to ask questions of the keynote speakers who will join us live after their presentations. You will also be able to ask questions of the panel following their discussions. Continuing medical education credit is being offered for this event, and registered participants will receive information on how to complete their CME. I'll close by saying that the FSMB is committed to helping the medical regulatory community provide leadership on this vital national issue. Our goal remains protecting patients and at the same time striving for better, more equitable care. Our state medical boards have much to offer as we seek to ensure access to quality healthcare for all Americans. Your participation today is a great step forward in that effort. Thank you all for joining us. I will now introduce our first keynote speaker. Mr. Marc Morial is President and CEO of the National Urban League, the nation's largest historic civil rights and urban advocacy organization. As a civic leader, he served as the highly successful and popular mayor of New Orleans from 1994 to 2002, and as the president of the U.S. Conference of Mayors. He also served as a Louisiana state senator. Prior to his public service, Mr. Morial was in private practice as an attorney in New Orleans. After the September 11 attacks, he led the effort to create a national safety and security plan for American cities, including the recommendation for a United States Department of Homeland Security. Mr. Morial has been recognized as one of the 100 most influential Black Americans by Ebony Magazine and one of the top 50 nonprofit leaders by the Nonprofit Times. He is the author of The Gumbo Coalition, a collection of lessons on the power of unity in a democracy and a leadership framework for America's changemakers. Mr. Morial is a graduate of the University of Pennsylvania with a degree in economics and African American studies and holds a law degree from Georgetown University. And now, let's welcome Mr. Marc Morial.
Thank you to all. And let me just say thank you to the Federation of State Medical Boards, its leadership, all of its members, its hardworking staff for the work you've done to organize the event today. I am honored to be able to speak to you on issues of paramount importance to every American, every citizen, everyone that loves and cares deeply about this nation, but also those who care about its ideals upon which it was founded. So I speak to you today not only as professionals who are in healthcare and medicine and science. But I speak to you as men and women, as mothers, as fathers, as grandmothers, grandfathers, aunts and uncles, sons and daughters, grandsons and granddaughters, people who are entrusted at this moment in American history with charting the course and charting the future for this nation, which will achieve its 250th anniversary in just 6 years. No conversation about the present and the future can be informed or effective or illuminated or meaningful or authentic without a reflection on the past. And certainly, part of the past is the immediate past. That past is the year 2020, one of the most consequential years in recent American history, and I think a year that will be understood as one of the most consequential years since the founding of this nation. I had the distinct pleasure on September the 6th of 2020 to climb the steps of the Canterbury pulpit at the Washington National Cathedral and to deliver an address on Labor Day. At that time and in that setting, where I was humbled and honored to be in a place of power, a place of grace, a place that many, many prominent men and women have stood, to talk to the nation about the 4 pandemics that had risen in 2020. Those pandemics, of course, include the most obvious, and that was the pandemic of COVID, which today we are grappling with, we are struggling with, as each day we hear about lives lost, families shattered, people ailing in hospitals and nursing homes with the wickedness of this disease. And then that pandemic has spawned the pandemic of economic downturn. In December, the nation lost over 100,000 jobs. And since the pandemic began, maybe only half of the jobs that were lost have come back. The human toll, those who cannot meet their obligations, their basic obligations of rent or mortgage, of support for food and clothing, and the basic necessities of life, is real and it's palpable. At the National Urban League, our own constituents have identified food insecurity, meaning we don't have enough to eat, as one of the most important challenges and needs of communities across the nation, where we are situated, where we work, and where we serve 90 American communities. That economic suffering is the second pandemic. The third pandemic is the pandemic of racial justice, which in many ways rose up as we witnessed the death of George Floyd on the streets of Minneapolis. His death was a killing, a homicide, a murder at the hands of one we are asked to respect because they wear a uniform, carry a badge, carry a gun. It has shattered the confidence of so many in the institution that are bound to protect and serve. And that pandemic of racism and racial justice has spawned new conversations and new actions in American life. And then there's the fourth pandemic, the pandemic of the American soul, the American spirit. What is it in the spirit of the American soul that would compel and incite some Americans to want to storm the citadel of democracy, the United States Capitol, to carry out violence against the building and against people who've been elected to serve? An unprecedented act in our history. We debate, we disagree, we have sharp exchanges, we fight at the ballot box, but we've never witnessed, since the Civil War, a denigration of the institution of democracy, the effort to diminish what the people have determined, an attempt to undermine the orderly transition of power. What is it in the American soul? Is it racism? Is it hatred? Is it misunderstanding? Is it sick and demented leaders who would seek to manipulate public opinion merely for their own power and aggrandizement? Whatever it is, we face these pandemics. And face them, we must. To pretend that they'll go away, to believe that they're aberrational, temporary, or fleeting would be a great mistake. It would be error. It would be grievous error to believe that. Instead, you're called. I'm called. We are called at this moment in American history to confront COVID in a responsible, equitable way. We're called to do what we must to rebuild the American economy. As that American leader who happened to be a disabled American, Franklin Delano Roosevelt, did in the 1930s. We're called on to confront racial injustice and to pursue racial justice in every element and institution of American life, and to recognize it for what it is, a social disease that has deep roots in this country, but a social disease we must conquer. We must eliminate. We must tear out. And I know you say, well, what should we do? And give me a minute. And I will offer just some thoughts. Not that I am the most knowledgeable, not that I am an expert, but my thoughts will be because of my lived experience. And the American soul, it would be missing the point to believe that this is just a partisan battle. That somehow politics is the beginning in the end. To not understand the need to build an American nation that respects and tolerates differences of race, differences of religion, differences of ethnicity and nationality, and sexual orientation and gender identity. And to fundamentally understand that people are people, people are human beings, made by the same creator, with, as the founding fathers said, the same inalienable rights. No government, no police, no army, no powerful economic interests can take those rights away. Not in a phony, superficial way, but in a real way, and an understanding that all too often in America, we've talked the talk and denied the rights. We've painted a picture and done something else. So we and you as responsible leaders on COVID, we must have a community-based distribution effort. It was good to see in New York City the beginnings of new locations to distribute the vaccine. It has to be in churches and schools and community centers. It has to be where people are. And there has to be a campaign of engagement, conversation, and education. It's not unreasonable for people to not trust. It's not unreasonable for people of color to not trust this vaccine, given the history of unauthorized and abusive medical experimentation on Black people. But it is therefore required that we engage and discuss and talk, that medical professionals who are Black, Hispanic, Asian, American Indian, and Native American, who've been part of the process of development and approval, be part of the conversation, to talk to people, explain to people, help people understand the vaccine, how it was developed, what its side effects may be. We have to have that kind of effort, not some sort of cheap effort to try to force people, but an effort to intelligently give people information. I trust when people have information, they'll make the right decisions. That's what we have to do with COVID. Wide distribution. I wondered when I saw that there was going to be a focus on distribution through pharmacies. Not to throw shade on pharmacies, but when you count the number of chain pharmacies in the United States and you divide it by maybe 200 to 250 million people, each of these pharmacies would have to vaccinate 9,000 people. Can you imagine 9,000 people being vaccinated in a 90 to 120-day period at the pharmacy in your neighborhood? The plan as initially developed was not well thought out. Now, with a new regime, a new team coming in, it is my hope that they'll strengthen this plan, widen its berth, develop an education plan. That's what we have to do on COVID. We have to rebuild the American economy in a way that recognizes that some have been hit harder. The Black unemployment rate and the Hispanic unemployment are back in double digits. And they had come down at the end of the Obama administration, and it continued to eke down, and now they're back up to where they were during the recession of 10 years ago. So it's got to be targeted attention on those communities and support for all communities. On racial justice, every institution in American life, business, government, higher ed, scientific, has to recognize that there's an element of racial structural injustice inside of their organizations. They've got to confront it. I had a business leader ask me for thoughts about how to increase the number of African Americans on his executive team. I said, well, when you want to make something happen, what do you commonly do? You make a decision to do it. You don't wring your hands and ask, will someone be upset? Will some people not like it? You make a decision. Leaders of institutions have to make decisions to confront racial justice by developing a mechanism and a method to have courageous conversations. They're not easy. They can be painful. They can be hurtful. To help people understand the pain, but to help people align towards moving forward, moving in unison, moving collaboratively. We have to understand the long legacy. But to understand the legacy is not to engage in wholesale condemnation of the history of the nation. I'm proud when I look at men and women. My parents were part of this generation. They were soldiers, civil rights soldiers in the 50s and 60s. They were black and white. They were Jew, Gentile, Protestant, and Catholic, and they fought to end legal segregation. They risked. Some died. We have to muster up the same level of courage today as this nation's diversity, its gumbo, its rainbow, its mosaic begins to increase. We have to understand these deep economic and educational disparities, and we have to recognize they didn't happen by merely the law of nature. It happened because it was intentional to create it. It would be a long conversation. You'd have to invite me back to give you the history since 1619 and through 1776 and through 1789 and through 1808 and 1850 and 1860 and 1865 and 1876 and 1896 and into the 20th century to 1954 and 55 and 63, 64, 65 and coming forward into the 70s, the 80s, the 90s, and the 21st century. Suffice it to say, you lead an institution today, you need a plan. You need a plan for, let's call it diversity, equity, and inclusion. Let's talk about ending racism. Let's talk about ending religious bigotry. I am a person who has had tremendous blessings of life, who's passionate about the work I do, but who experienced a tremendous amount of racism as a young boy growing up in my hometown of New Orleans, because I was part of the generation that integrated every school that I attended. the elementary school, the middle school, and the high school I attended, I was one of very, very few African American students. And I got called names, and I was bullied, and I felt marginalized. But it made me tougher, it made me stronger, and amidst it all, I understood that there was a difference between a system and then there were people who lived in the system and people who were working to change the system. We're at a moment in the history of America where you and I and each and every one of us have to recognize that what we've seen and what we have experienced is a clarion call for us to build a better America, to build an America which is tolerant, that is inclusive, economic systems that work for everyone, educational systems that provide pathways for all. We have to do that work. And I know that those of you who are in the front line understand health disparities, the social determinants of health, and all of the great challenges that we face. But one thing we need to do as we rebuild our public health system is build it back differently, not put Humpty Dumpty back together again. Humpty and Mary fell off the wall. We got to build a different Humpty and a different Mary Dumpty in healthcare and across the land. I look forward to some questions and some conversations. And if you'd like to learn a little more about my perspectives and experiences in leadership, I've written a book. It's called The Gumbo Coalition. It's 10 lessons on leadership, and I'd recommend it to you. And I appreciate the time you've spent with us. I look forward to the Q&A that will follow, and I thank all of you for your time and your attention today.
Well, thank you, Marc, for that wonderful presentation. It was
Thank you.
compelling. I've known you for quite some time, as you know, with Julie and I, your sister, having been interns together. And this is just a very special moment. So I just have to say thank you very much.
Thank you very much. Yeah, thank you.
So we have a few minutes of questions from our online audience. And if you have a question or comment, please use the question and answer feature provided on your screen. So let me check here and see where we will start, Marc.
Thank you.
Absolutely. Okay, so we do have quite a few questions, actually. I'll start with, as the former mayor of a major American city, what lessons did you learn about health equity in urban settings, and what should we do, what do we need to do to address it?
Well, you know, cities have a role to play in health equity, and but are not the primary drivers of the healthcare system. The states play a much more significant role than city governments in most places. In some places, county governments own hospitals and health facilities. But what you learn is, and I think what I've learned not only from being mayor of New Orleans, is that when it comes to addressing equity, it takes intentionality. It doesn't take serendipity. It requires that you precisely attack the issues, the root causes, and identification of equity. I mean, today, over the last few days, President Biden signed a new executive order that will require every single agency of the federal government to examine both its policies, its practices, and its programs to identify disparities and inequities, which is an example of intentionality. It's an example of forcing the examination and the calling out with the idea that that will create a framework for rectification, for responses, for policies that address it. So I think the most important thing I think we've learned in the 50 years of civil rights is that when it comes to racial justice, we've got to be intentional.
Okay, thank you. Now, what worries you most about our ability as a nation to achieve racial healing in the U.S.? And what's the biggest thing that is holding us back?
One thing that bothers me is the declaration of victory prematurely. The idea that symbolic victories end racism. When President Obama was elected in 2008 and took office in 2009, there were those who created, promoted, and invented a narrative that America had become post-racial, simply because a black man had won one election. And it began before he served one day in office. It began before he even gave his inauguration speech. And I think that the tendency to want to declare victory, or to say because one bill, one initiative has passed that we've ended systemic racism, we have to be completely, if you will, aware that that is not a good idea, that is not the way to go, that's not the appropriate approach to take. And that it requires long-term sustained effort and progress, because we're dealing with a system, when we talk about racism, which is really the assignment of opportunity based on physical skin color, and an entire system of winners and losers, economic winners and losers, social winners and losers, was created, and it is a system that's 500 years old. And it's not going to be dismantled in 6 months or a year or even 4 years. So it requires an understanding that we have to work long, we have to work hard, we have to continue to be intentional. And I worry about people getting tired or fatigued, or believing that symbolic victories yield progress, although I'll celebrate the symbolic victories. I'll cheer about the symbolic victories, but those symbolic victories are like making a first down in football. They don't represent a touchdown. They don't represent a W, either, a win of a game, much less making the playoffs in a season or going to the Super Bowl in a season.
Another question, Marc. What steps can universities and their hospitals take to promote public health in their communities?
It's a great question. I think that institutions like universities or businesses or hospitals should start their efforts by doing what some have referred to as a civil rights audit, an examination of disparities and discrimination. Sometimes discrimination is both implicit and explicit. It's not as easy to wrap your arms around. I think institutions have to be introspective. They have to examine and they have to identify, and by doing so, they are better poised to take the steps necessary. Secondly, after that examination, there has to be a plan of action. And that plan of action has to have goals, timetables, and measurements. And obviously, one-offs don't work. Symbolic gestures, while I said earlier I'd applaud them, are not enough to confront this situation. So I think that a university or university hospital should really step back and ask themselves, put a task force together, put a work group together, put the right people on it, get some professional assistance. Say, let's examine our hiring. Let's examine our community connectivity. Let's examine policies and procedures. Let's examine who we do business with. Let's examine whether there are disparities in quality of care. Let's examine all of that. Let's ask the people who use our services, who are affected by it. That's a starting point if you're going to be serious about dealing with these difficult challenges.
Now, and can you talk a little bit more about food insecurity and why this has become such a big problem in our cities?
You know, it was, I'm not going to say surprising, but at the beginning of the pandemic, we conducted a survey. It was conducted by all of our affiliates across the nation, and we listed a number of issues to determine where the stress in the community was greatest. Was it with jobs? Was it with housing? Was it with food? At the beginning of the pandemic, 80% of the people we surveyed said it was with food. Hello? Yeah, it said it was with food, that food insecurity. So we immediately, a number of our affiliates launched into action. They moved very quickly and decisively to provide, if you will, grocery bags, food boxes, and other forms of assistance for people who are food insecure. What we have to keep in mind is when the schools closed down, there were many, many children across America who got, in some cases, 1 or 2, some places 3 meals were being provided Monday through Friday in the school setting. And that when the schools closed down, or when the schools went remote, then all of a sudden, those meals were not there in many places. So food insecurity truly impacts children. When children are eating not the right thing, they're eating snacks and non-nutritious food, they are food insecure. It's not simply not having food, it's also not having the right food, not having healthy food, not having fresh food makes one food insecure. Food is an element of good health.
Thank you. And then one final question, Marc, and that is, thank you for referencing intentionality and referencing the need for the study of history to learn that these disparities are not simply serendipitous. What do you say to those who argue that bringing up the past simply promotes division rather than heals it?
It's so interesting that people who say that bring up the past with everything else. When we talk about the American Revolution, when we celebrate the Constitutional Convention, when we talk about World War I, World War II, when we discuss a President Lincoln, a President Washington, a President Jefferson, when we study the Romans, the Greeks, when we study the Renaissance period, what are we doing? Bringing up the past. We're bringing up the past. History is essential to learning. And those that suggest that are 1, illogical, 2, inconsistent, 3, wrong-headed. We utilize history as a component of learning everything we do in the arts, in the humanities, in science, and medicine. Why not when it comes to race and civil rights? So in bringing up history, we're also recognizing also a fact that so much of how history was written in an incomplete fashion or an inaccurate fashion. I'm a son of the South. And if you think about the Lost Cause movement, which I learned about and it was glorified in my elementary school history books, the narrative that the Civil War was fought and that the South's cause was just and it was about states' rights, when in fact it was the defense of slavery. So I just feel that when people say that, we should dismiss it because what are they saying? Let's not talk about the Romans. Let's not talk about, if one is, in most religions, talk about Christian religions, talk about Judaism, when one goes to worship, the essence of worship is learning about history. It's prayers that are associated with history. It's the experiences of people who lived long ago that we look to for inspiration and knowledge. The essence of it is history to inform the present and the future. So racial justice is no different. It's the same basic, I think, elements. We study history, we examine history, we debate history, because we want to inform the present and the future. So I'll tell people, don't fall for phony arguments.
I like that. Well, Marc, again, I thank you. And we are very grateful, and I am very grateful that you were able to join us today.
Welcome back to our symposium. For those of you who are just joining, we are about to hear from our second keynote speaker, and then we will finish the symposium with a panel discussion. We are very honored to have Dr. Marc McClellan as our second keynote speaker today. Dr. McClellan is the founding director of the Duke Margolis Center for Health Policy at Duke University, nationally and internationally recognized for research and educational initiatives to improve health policy and health. Dr. McClellan is a physician and an economist who has addressed a wide range of strategies and policy reforms to help improve healthcare, ranging from payment reform to strategies for more effective biomedical innovation. Many of you know Dr. McClellan as a former administrator of the Centers for Medicare and Medicaid Services and a former commissioner of the U.S. Food and Drug Administration. In both positions, he developed and implemented major initiatives and reforms in health policy. He has also held senior policy positions in the White House and U.S. Treasury Department. Before joining Duke, he served as a senior fellow in economic studies at the Brookings Institution, where he was director of the Healthcare Innovation and Value Initiatives. Dr. McClellan received his PhD from the Massachusetts Institute of Technology and his MD from Harvard Medical School. And now it is with great pleasure that I introduce to you Dr. Marc McClellan.
Thank you, Dr. Walker-McGill, and also thanks to my friend Lisa Robin and the entire FSMB community. I appreciate everything you all are doing at such a challenging time for the country to help assure patient safety and confidence in our healthcare system. And that's what I want to talk with you all about today, COVID-19, healthcare response and resilience. And my next slide, the topics that I want to cover include an overview on kind of where we are with healthcare reform and healthcare financing during and beyond the pandemic. As Cheryl mentioned, I'm currently the director of the Duke Margolis Center for Health Policy, where we work on a range of health policy issues, particularly related to improving healthcare, getting healthcare that transforms with technology, that stays up to date, and that meets the challenges that we face in terms of new pandemics as well as other threats to public health. So that brings our work a lot around how financing, other regulatory policies can support better care, and certainly reflects important interactions with the work that you all do every day. I spent a few minutes on a COVID-19 update. We're doing a lot of work on COVID, and happy to follow up on those topics with you all as well. And then how care and payments are changing as part of the COVID-19 response. And along the way with all of this, some of the implications for the regulation of healthcare providers as we're moving into a new era. I don't think healthcare is going to go back to the way it was before. We certainly can't afford for that to happen from either a health standpoint or a cost standpoint. And just looking ahead, as the next slide shows, I think about the future of healthcare. Where are we headed? Over my career, I've seen this move a lot in the direction of upstream. So care that is still about responding to urgent health needs when people are severely ill. And again, living through the COVID pandemic, we're seeing heroic activities by our hospitals and healthcare frontline providers all over the country to make sure that when people do get really sick, we're doing everything we can to support them. But as you know, in so many areas of chronic disease, we're learning how to move upstream through better, more accurate diagnostic technologies that make it easier to prevent heart attacks, to detect cancers, with now a move towards what may be blood biopsies for multiple cancers. And along with that, some more advanced technologies that help intervene and intercept progression of disease. We also know a lot more than we used to about the importance of prevention. And in a lot of the work that we do with healthcare systems, we're seeing strong interest in organizations finding ways to not just treat patients when they come in for their office visit or a checkup, or worse, with a preventable complication, but help meeting them where they are, taking care out into the community, using digital technologies and apps to support identifying risk factors and helping people respond to them, even getting into addressing some of the social factors that we've seen are so important in health risks here in the pandemic, issues related to hunger and access to safe places to exercise and the like. Finally, we know that healthcare doesn't solve every problem. We still have to provide good supportive care for people who need it. But all of these things we can potentially keep doing better in looking ahead. And again, our work in these areas focuses on things like how can we pay in different ways that encourage these steps to move upstream, that support healthcare providers that are trying to provide more comprehensive efforts to assist their patients in staying well in the pandemic. This means things like understanding if they're high-risk patients or facing ongoing exposures to COVID, maybe pre-positioning tests that they can use at home, supported by telehealth if they do have an exposure, and then quickly getting supportive care. And we have some treatments now that are at least promising to work, monoclonal antibodies for patients who have recently been diagnosed and are in high-risk groups, not to mention the importance of getting vaccines to the people who need it the most. That's upstream care, and that's the kind of thing that reforms in payment and other supporting healthcare reforms can do. And while I'm talking about COVID, this applies to much of the rest of our healthcare system, again, with earlier diagnosis possibilities for cancer, with technologies that may be emerging to detect and intercept the progression of degenerative conditions like Alzheimer's disease, not to mention the advances available in many other conditions to move care upstream too. Well, we know we need to make further progress on these areas based on what's happening with COVID right now. You know, the definition of a pandemic, as you're looking at the surge in cases that we're living through now, the definition of a pandemic is a pathogen for which there are no known medical treatments. And in just the past year, we've seen tremendous progress, but we are far from done. Right now, we're probably coming off what is hopefully the biggest, hopefully the last acute peak of the COVID-19 pandemic. You can see on this slide at the left, this is about a week out of date now, but shows the post-holiday surges. The numbers seem to be coming down in most part of the country. We're doing a lot more testing, so we're doing a better job of detecting cases, but some worrisome trends out there as well, with new variants emerging that we aren't testing for very well yet. It's another area where we need to do a better job of upstream detection and diagnosis and prevention-oriented policies. So the next slide shows that we are seeing very high rates of cases. 587 new confirmed cases per million corresponds with this high level of activity. You think about that over a couple of weeks. What that means is that on average in the United States, if you're in a group with 8 to 10 people, one of them is going to be actively infectious. So that's why there's so much attention to these non-medical measures to help control spread today, even as we're starting to get vaccines off the ground. The U.S. has had a really tough surge in the winter, but we are by no means alone. As you can see from this chart, report right now, or as of last week at least, the United Kingdom, Spain, we're facing higher rates of intensive and higher intensity of case spread, and even countries that have been relatively spared so far during the pandemic, like Germany, are seeing worrisome increases in cases. So this is still a worldwide phenomenon. The good news is most of the country cases are coming down. What hasn't yet started coming down much are the hospitalizations and the deaths. And the next slide, the hospitalizations typically lag the cases by a couple of weeks, and we're starting to see, fortunately, a decline in hospitalization rates, and right around now we should be starting to see more significant declines in deaths, and what is, again, hopefully, but certainly not guaranteed to be the last surge of the pandemic. And this was obviously the big issue for the presidential campaign, with the next slide shows President Biden running, essentially staking his presidency on having a more effective response to the pandemic that includes 7 major dimensions. These include things like relying more on transparent discussion of the science. I get used to seeing Tony Fauci more regularly, but among these different elements, I wanted to particularly call out the vaccination strategies, because that is what is going to get us out of the pandemic, and it's been in the news a lot lately. But on the one hand, we've seen tremendous progress over the past year because of kind of an unprecedented effort to make a long linear vaccine development process much more hyper parallel, with several steps happening at the same time. Clear guidance and preclinical testing of potentially effective vaccines, setting up large-scale clinical trials that could be done in the way that they're done for drugs under normal circumstances, so-called phase 3 trials, where you look in large populations to see about effects on outcomes, not just showing that there's an immune response, but effects on outcomes, effects on safety, setting those up and conducting those studies at large scale, at the same time as we went ahead and started doing manufacturing, joint collaboration between companies and the federal government, spending over $15 billion before we even knew if any of these vaccines worked, to get to the point where we are today, when the vaccines could be the earliest vaccines, the so-called mRNA vaccines from Pfizer and Moderna, were able to show safety and effectiveness using these very high standards in less than a year after the initial discovery of the SARS-CoV-2 virus, and getting into arms within just a few days of that occurrence. Well, there are other key parts of the pandemic response here too, which I'd be happy to discuss with you all further. But just to stick with the importance of vaccines for a little while, on the next slide, we are making progress. It's not as fast as many people would like. The president set a goal of 1 million doses per day being administered, and we've actually hit that level, or averaging more than 1 million doses now over the past week. And you can, this chart's a couple of days out of date. We're up close to 24 million vaccines administered at this point. But that clearly is a big gap from where we need to be to get to a level of protection in this country that can prevent the devastating effects of the pandemic. And among some of the concerns about where we are now is that only about half of the doses that have been distributed to the states have actually been used. There are a number of reasons for that. One is that many of the providers who have received these doses, these shipments, are keeping some of them back, knowing that this is a 2-dose vaccine, and with some uncertainty about just how much supply will be available next week and the week after. We're in a pandemic and the manufacturers are ramping up, but there is not complete clarity in these complex manufacturing processes. So some of those doses are being held back. Plus, we're seeing a lot of variation across the states in just how easy it is, how effective they are in getting shots in arms, with some states, as I think the next slide shows, going much faster than others. So we're up to about, on average, maybe 5% of our adult population being vaccinated, which is way short of where we need to be for any kind of herd protection or large-scale control of the pandemic. But there are variations in that. West Virginia, in particular, doing well with a combination of relying on their National Guard and relying on their healthcare providers, particularly pharmacists, but also community physicians participating in some of the early vaccination efforts with the highest risk groups. But with this challenge in getting the shots in arms, you've seen some revisions in the way that our federal policies are prioritizing getting vaccines out to the public. And the next slide, which talks about vaccine prioritization, kind of goes over where we started and where we are now. We started with focusing on so-called phase 1A, the frontline healthcare workers, 20 or so million people, the residents of long-term care facilities that account for more than a third of the deaths from the pandemic, so very high-risk population. It's about 24 million people altogether. We are well short of finishing that group because of the challenges in reaching some of these populations and the logistical challenges, but also some people in these groups not wanting to be vaccinating, not accepting the vaccine yet. We started to see these gaps emerge between the number of doses available and the number of people getting vaccines. One of the responses at the federal level and in many states was to open up the availability of vaccines to somewhat broader groups. There was a very short phase where the federal government was recommending so-called phase 1B, which was also adults age 75 and over. But then a couple of weeks ago, as this gap in available doses seemed to be growing, HHS in the Trump administration expanded to a broader set of the population, close to 150 million people altogether, including people over 65 plus people with chronic diseases that place them in a higher risk category. The Biden administration modified that somewhat when the new administration came in, limiting to adults 65 and over, plus some categories of essential workers, and continued vaccination in the long-term care facilities, about 100 million people altogether. So we're not going to get to that number for quite some time, even if we can continue at this pace of over 1 million vaccinations per day. So that's 2 doses per person, and that means in the first 100 days we might get to somewhere in the 60 to 70 million range. So the question is, are there ways to accelerate this process while also recognizing that there's a trade-off here? The more you open up vaccinations to people who want it, the easier it's going to be to get more of those shots in arms. And that's really important at the point when we're in such a high level of surge around the country and worried about the emergence of more resistant variants and more serious strains with such a high level of cases all over the country and all over the world. So very important to get shots in arms. But one thing that's clearly happening as we've expanded the groups is that not all people in those higher risk groups are getting vaccinated, and particularly not people who, for various reasons, are hesitant to take the vaccine or have had problems in getting access to it. And this is really important in the pandemic, as the next slide shows, and as you all well know, we've had huge disparities emerge across different groups, urban and rural, but especially race and ethnic groups. This may be a little bit hard to see from your screens, but this shows the ratio of cases and hospitalizations and deaths across different racial and ethnic groups: Black, Hispanic, American Indian, Alaska Native, and Asian, relative to the level of 1 in these charts, which is white Americans. And you can see in particular very big differences in mortality for Black Americans, for Hispanic or Latino Americans, with the trends for Latinos actually getting worse, not better over time, due to differences in case risk That's mixed up with jobs and living conditions and other social factors, as well as differences in rates of hospitalization. Those two numbers cumulatively are much larger for Blacks and Latinos or Hispanics than they are for whites, and especially again for Latinos have not been getting better over time. And the concern is that if we see the same levels of disparities emerging with the vaccines, these inequities, these gaps in outcomes, are likely to get even larger. So what can we do about this to get both accelerated access to vaccinations as well as addressing equity in the process? Well, this is where healthcare providers like the ones that you all regulate come in. There have been a lot of steps in the last couple of weeks to try to increase the availability of mass vaccination sites and deployable mobile sites, including testing sites that have been used for access to testing in underserved communities, converting those to conducting vaccinations. And one of the steps that have been very effective in West Virginia is kind of leading on the top of the leaderboards has done this, is using local personnel to staff these sites because they know their community. It helps with trust. It helps with being there when you can set up an event at a nursing home. It turns out that if you just try to go in there once, many of the patients have not had consent. They may not be able to give consent, so it helps to be able to go back a little bit later. Having the local workforce that can help with that is turning out to make a big difference. So that applies for pharmacists. It applies for clinicians who are not busy in the hospitals right now in terms of helping with some of these vaccination efforts. Now, it's not only about getting the workforce there. It's also about getting effective support personnel for National Guard and other locally currently deployable resources, and people can help a lot. Effective scheduling systems, something that we've really been behind on, but there's some good systems starting to emerge in different parts of the country. More clarity about upcoming vaccine supply, that's a priority for the new administration. And then very importantly, more effective outreach and education. The next slide talks a little bit about how we might be able to accelerate beyond where we are now. So 1 million doses per day, again, may seem like a lot, and it's a good benchmark, but as the administration is talking about now, they're kind of seeing that as a floor. So how can we get to 1.5 million, 2 million? Well, first of all, we need enough vaccines available that we've got the supply, and that's starting to increase. There may be some further steps that can happen there. Second, the administration has proposed in that COVID recovery plan a lot of funding to expand our public health workforce, 100,000 new workers, and a lot of funding for additional deployments of the National Guard. But what I want to emphasize, and something that may come up in the work that you're doing with physicians, is that we do have a workforce available now, that we don't have to wait for the next round of legislation to be passed and for that to be implemented. There are these frontline available workers through pharmacies, through different clinical settings that are turning out to be an important workforce, like right now, to help increase the availability of support for doing vaccinations at a larger scale. And so what I hope can happen with support from the administration is guidance to the states on how to do this at a bigger scale, relying on you go to war with the army you have now, or at least we need to, because of the urgency of dealing with the COVID crisis, getting more of the healthcare workforce to participate in these activities on top of the effective but very limited public health workers who are available and the potential additional support that could come if and when the Biden rescue plan gets enacted by Congress. And again, good opportunities for healthcare workers to support those efforts. Just real quickly, one other big challenge here is the support that people have for being willing to take a vaccine. The next slide shows how much that went down during the fall, during the political season, when vaccine access and speed of access became a political issue rather than a scientific one. That has recovered significantly, with now about 65% of Americans saying they either would be likely to or potentially willing to be vaccinated. Those are about as big numbers as Gallup has ever seen, with a lot of Americans very hesitant about vaccines. But as you know, we probably need to do even better than that to get to a level of herd immunity. And there are some differences. The next slide shows people who are less educated are less comfortable with the vaccine. Non-white adults, there's a big gap back in the fall. That's diminished somewhat, but less confidence there too. And as the next slide shows, Republicans, that's the red part of this line, Democrats have had a big differential. There was one at baseline, but that differential in terms of confidence about COVID vaccine has reemerged. In fact, it's going to be hard to get those numbers up much above 65% unless we can get past some of the politicization that's been part of the whole pandemic response. I did want to shift gears a little bit and talk about the impact of COVID on our healthcare system, which the next slide presents. As you all know, when we went to the shelter at home orders in the spring, there was a huge reduction in utilization in the healthcare system, with 40, 50%, 60% declines in utilization. And because most of our healthcare providers are still paid on a fee-for-service basis, workforce declines, healthcare workers being laid off at a time when we really needed to be getting ready for preparedness. $200 billion in financial assistance from the federal government and the CARES Act helped respond to some of that impact. But still, we've got a lot of focus in our healthcare system on kind of reopening elective services, many of which are badly needed and shouldn't be delayed. But at a time when we really need our healthcare system to move more upstream and help with collaboration with public health and prevention, as well as restart the services that are most important, it's challenging in the financing system that we have in most of the country. Good news is, and the next slide kind of highlights a bad side of this, but good news is that most of these health services have recovered. In some parts of the country, like California, have been very hard hit in the past month, seeing again some declines in elective surgeries and the like, but most of them have recovered. Where we haven't recovered is in areas like primary care visits. And as this slide shows, these are 3 different types of preventive services: colonoscopies, mammograms, and vaccines, where we're still running about 20-30% below baseline rates as people are staying away from primary care, which is very worrisome for the future, not to mention concerns about people having well-coordinated care for the different medical problems that are being exacerbated in the pandemic as well, including behavioral health care. So there are some healthcare organizations that have been able to respond better to this setting, and it maybe is back to that path of the future that I was talking about earlier. For those of you who, like me, work a lot on payment reform, maybe this next slide will be a little bit familiar, but we've been seeing a shift in our country away from fee-for-service payment towards payments that are more linked to people or episodes of care, so accountable care organizations or bundled payments. While those models of payment do have some downsides, what they do allow is a disconnect between volume of traditional medical services and what people get paid, and a more flexibility for the healthcare providers in these alternative payment arrangements, more financial security and more ability to adjust what they do in their care models to match what it is that people need. And again, increasingly, that's upstream support, more use of diagnostic tests, more use of team-based approaches to care, care that can be delivered at home, not in an office, care that's focused on preventing complications rather than just dealing with the downstream consequences. And we've seen in the pandemic, we've got a lot of work on this in our center at Duke University, as the next slide shows. The healthcare organizations, the providers, physicians, and providers they work with who have moved away from fee-for-service have been less impacted by these revenue changes. They've had much more financial stability, and they were typically already already doing more of some of the activities that have proven to be very helpful in the pandemic, like being able to deliver services through telehealth, and not just a telehealth visit substituting for an in-person visit, but a virtual care model that incorporates telehealth, remote monitoring, support from allied health professionals and the like to manage chronic diseases. Or they were already doing things like dialysis services at home or chemotherapy administration at home, and they've been able to expand those efforts. Very much needed in the COVID pandemic. So the next slide just describes some of these care reforms that have turned out to be helpful for COVID, and that I sure hope we keep around. So having more team-based approaches to care for managing chronic conditions, physicians augmented by team staff and supported by virtual care, integration of behavioral health services, home-based care models, increased attention to social isolation, mental health issues, and other social factors that have been disrupted for so many Americans, not restarting some of the so-called low-value care in our healthcare system. Wasn't needed before, certainly not needed now when we need to be redirecting our resources, and spending more time working with public health on early access to testing, like that example I gave you before. There are many examples, as the next slide shows, of organizations that have done these steps, that have tracked their patients at high risk for COVID and reached out actively to help them manage conditions and complications, not only related to COVID, but their other underlying medical problems. There are many organizations that are working on the social drivers of health. This does take some new kinds of capabilities, as the next slide shows, establishing a real telehealth remote monitoring capabilities, having a different approach to designing a workforce, building out longitudinal data systems, and the capacity to support care at home and track patients over time. Definitely has some implications for regulation of medical practice in terms of what clinicians do versus the teams working with them. And again, steps that I hope we see continue in the years ahead. Based on this kind of experience, the next slide shows 5 other former CMS administrators and me. We collectively wrote a letter with a proposal for encouraging this shift in care to make it permanent, to maybe develop assistance for healthcare providers in the pandemic that helps them move into these new payment models and do more, say, with helping with vaccination and early outreach and management of COVID patients in the short term, but move further away from fee-for-service in the long term. That can apply, as the next slide shows, both to medical practices and hospital-based systems, moving to alternative payment models like advanced medical homes or physician-led ACOs or direct contracting. And we're seeing a number of healthcare organizations, as the next slide shows, implement these kinds of models. Where I am now in North Carolina, our Blue Cross plan has implemented some new reforms to their primary care providers that were really hard hit financially in the pandemic, to give them more per person payments now for the persons that they take care of for their whole set of patients, in conjunction with the physician groups moving into these physician-led ACO models over the next couple of years. So that they won't be in this position again if there is another disruption in care, and so they can actually make some investments now as they reopen their practice and solidify it for the future that help prepare them and help them succeed more in these alternative, innovative care models. We have a lot more resources. The next slide shows at our website, and encourage you to follow up with us if you want to hear more about these steps. Like I said, we spend really all of our time thinking about the policy implications of trying to move to better care models like the ones that I've talked about with you all tonight. And I hope we get some more opportunities to work together, both to get through the current pandemic and to build a more resilient healthcare system for the future. The last slide, just to thank you. Thanks very much for the opportunity to talk with you tonight, and I'm looking forward to following up on the points that I've discussed and anything else that you all would like to talk about.
Thank you, Dr. McClellan, for an outstanding and comprehensive presentation. And we certainly will take you up on the suggestion that we get together at a later date to continue this discussion. We now have a few minutes for questions from our online audience. And if you have a question or comment, please use the Q&A feature provided on your screen. So let's go to the questions. I can tell you there are going to be many, which is great. Okay. Now, the first one is, in your presentation, you talked about the importance of building trust among Black, Hispanic, and other populations in order to reduce inequities in addressing COVID-19. What steps should we be taking to build trust?
Well, Cheryl, it's a great question. And I just want to emphasize that this is going to be a big deal with vaccination. Even in just these early phases where we've mainly been vaccinating people in nursing homes and people who are frontline healthcare workers, we're seeing, at least anecdotally, some pretty big differences emerging by race, ethnicity, and also across types of workers. So high rates of vaccinations for doctors, fairly high for nurses, but for many of the other workers in hospitals and healthcare organizations, the numbers are much lower. And we're sort of going down the list, as I talked about in my remarks, of broader access to groups of, everyone 65 and over, broad range of younger essential workers. Those are important groups to vaccinate too. But I think we're going to find big disparities emerging. So really appreciate the question. In terms of steps that seem to work, there have been a lot of efforts to engage. States that have been most successful in getting rates up, not just of, say, nursing home residents, but also nursing home workers in places like West Virginia and other states, is they started early. They engaged with the public health departments and workers, engaged with those communities and tried to make sure they were answering questions, providing resources, working with people from the communities, clergy, other trusted individuals. There's really no substitute for that kind of participation in an important vaccination process like this one. On top of that, I think you're going to see some more help coming from the federal government and other sources. We support a group called the COVID Collaborative, which is a national effort made up of many former federal and state health officials, leaders. It's co-chaired by Deval Patrick, former governor of Massachusetts, and they've come up with a number of resources as well. They're also working with the Ad Council on a public education campaign with targeted messages to the groups who are having access to vaccinations now. So there's some resources available from groups like that. I also want to give a note to the National Medical Association, which for physicians has put together a number of resources and collaborations to try to reach some of the lower income and traditionally underserved communities, Black and other minority communities as well. Groups like this that connect directly with the communities involved are really important. Also seeing more examples of stories that people are telling as more people get vaccinated, getting those stories out there that people can relate to. But this is a real issue that is going to continue to be a concern, especially if we only focus on getting the maximum number of people vaccinated, not getting the participation from all of these groups.
I have another question. Actually, there are many, but we have time just for a few. Can you talk about racial inequity in the medical workforce? Why do you feel the numbers of minorities employed in healthcare systems are still lagging? And what role do you think state medical boards might be able to play?
Well, I think you're going to see some actions from the new administration to address a lot of aspects of health inequities, racial and ethnic inequities in our healthcare systems. That includes in the workforce, it also includes in access to care and includes health outcomes as well. And I think one important part of this is just focusing on it. So we've paid a lot of attention. I talked about some of the payment reforms that have been implemented in my talks, where payments are linked to things like getting better outcomes, reducing hospital admissions or readmissions, or getting having more of your patients with their cardiovascular risk factors under control. Most of those efforts up until recently did not break down and focus on specific subgroups in the population. And we've seen in recent years a lot of well-meaning tools implemented that were designed to improve access to care or identify and help address higher risk patients that, because they didn't take account of race and ethnicity, ended up actually being harmful by fact that, for example, white patients with chronic conditions are more likely to go to the hospital when they have a complication. And so if you're just measuring, well, who's likely to have a complication, you'd focus on white patients, even though the real access to care issues and poor outcomes are in Black or other minority patients. So making it explicit, and in regulatory approaches, we're starting to see now in many of the programs that we work with at state level, Medicaid programs, the federal level, and again, the new administration is going to emphasize this, explicitly tracking differences in access and outcomes by race. So if there's an analogy, I think in the state regulation side, it's maybe looking at features of the workforce and tracking those kinds of measures. We're seeing that happen in corporate America more generally, with a push towards more representative participation in boards and leadership programs. I think you got to call attention to it and measure it as a foundation for taking more effective action.
Thank you. Now, emergency medical systems under the NTSB consists of trained professionals such as EMTs. They have national education standards, certification, and licensure. Why don't we use this valuable organized workforce to help with immunizations?
I think it's a great idea for the workforce. Actually, emergency room use in the pandemic is down. It surprises a lot of people because use for COVID is actually up, but emergency calls, ambulance calls, emergency department use is lower. I think part of the problem may be that hospitals are getting hit so hard right now with the surge in cases that they're not really thinking about how they can redeploy those personnel to help with the vaccination efforts. And I think as people get better at understanding just what are the best ways to vaccinate not only lots of people, but the highest risk, highest priority individuals as well, they're going to turn to using more health professionals. So we're seeing more use of pharmacists in many states, as I talked about in my remarks, especially locally based pharmacists who know their community. We're seeing more use of nurses. Some states are starting to use firefighters, other first line responders, National Guard, and I think emergency response personnel could be part of that effort too. May not be delivering the vaccinations in the hospital. It might be at specialized sites set up elsewhere, but we really need to get up our increase our capacity right now. It'd be great to hire lots more public health workers, and I know the administration would like to do that too, but that's going to take legislation. It's going to take time to get the money out there. As you say, these are workers who are available now, and I think you're going to see more creative approaches to deploying different health professionals to make these vaccination efforts work.
And now the last question. Do you think that cohesive and complete education for all on the vaccinations would be the key to compliance? The person who submitted this said that they feel that clear disparities are present because education on the vaccine is not being offered to communities with different languages and literacy levels.
Yeah, it's so important. And I mentioned earlier some of the resources that are available to help provide some basic factual information about immunization. There are more of those resources available in multiple languages, and that can be adapted to additional sources. The Centers for Disease Control has made a number of such resources available and will be expanding them. And so I think there will be more resources coming. But I just want to go back to my earlier point that there's vaccination has been part of a political process this past year, and while it seems like many Americans are getting beyond that, the overall rate in surveys of people saying they're willing to be vaccinated has gone up. It's gone up for people from minority backgrounds too, but there still are important gaps there. So this is deep-seated, and while information is helpful, connecting it to participation in the community, working with local community leaders, people who know the individuals involved. So it's not just getting the information out, but getting it out with a personal touch from your physician, from a nurse, from someone in your community who you respect. It's an important complement to just getting the information out by itself. And that's where I think, as we were talking about earlier, allied health professionals and people who work with physicians could be really helpful.
Well, thank you very much, Marc. This has been such a great presentation. And again, I look forward to following up with you sometime in the near future. Welcome back to our symposium. We want to thank Mr. Marc Morial and Dr. McClellan for their excellent presentations. We also want to thank you, our online audience. We appreciate your participation. And now we look forward to a stimulating panel discussion. It is my pleasure to introduce Dr. Hank Chaudhry, the President and CEO of the FSMB. He will moderate the session with the panelists, and he will introduce the panelists. Dr. Chaudhry has had a distinguished career in medicine, and he has brought outstanding leadership to the FSMB since joining the organization in 2009. Dr. Chaudhry?
Thank you very much, Dr. Walker-McGill. What an inspiring afternoon it has been. Our keynote speakers, the two Marcs, Marc Morial and Dr. Marc McClellan, have been phenomenal. What we're going to do now is to focus our discussion on the impact of health inequity on medical regulation and what role our professional community might play in addressing this issue. So it is with great pleasure that I introduce to you our three distinguished panelists. Joining us are Dr. Aletha Maybank, the American Medical Association's Chief Health Equity Officer, Dr. Leonard Weather, Jr., a physician member of the Louisiana State Board of Medical Examiners, who is also past president of the National Medical Association, and Dr. Diana Currie, a physician member of the Washington Medical Commission. Dr. Maybank, I've had the honor and privilege of knowing for 15 years. She serves as the Chief Health Equity Officer and Group Vice President for the American Medical Association, the AMA, where she focuses on embedding health equity across all the work of the AMA and also leading its Center for Health Equity. Now, prior to joining the AMA in 2019, Dr. Maybank served as the founding Deputy Commissioner for the Center for Health Equity at the New York City Department of Health and Mental Hygiene. She also served as the founding director of the Office of Minority Health in the Suffolk County Department of Health Services on Long Island when I was Health Commissioner. In 2012, along with a group of Black women physician leaders, Dr. Maybank co-founded We Are Doc McStuffins, a movement inspired by the Disney Junior character Doc McStuffins and shining a light on the critical importance of diversity in medicine. Dr. Maybank received her bachelor's degree from Johns Hopkins University, her MD degree from Temple University School of Medicine, and a master's in public health degree from Columbia University. She is a pediatrician and preventive medicine public health physician. Dr. Weather is a physician member of the Louisiana State Board of Medical Examiners, and as I mentioned, the past president of the NMA, the National Medical Association, an obstetrician gynecologist. Dr. Weather has presented more than 190 peer-reviewed presentations and papers on pelviscopic surgical treatment of infertility, endometriosis, pelvic pain, and fibrosis. He is a medical and surgical leader and tireless innovator known for inventing a surgical procedure that assists in the prevention of organ injury during laparoscopy. Now, Dr. Weather has held a variety of leadership positions in organized medicine, including service as president of the New Orleans Medical Association and the Louisiana Medical Association. I'm seeing a Cajun theme this afternoon. He currently serves as the president of the Northern Louisiana Medical Association. He's a former member of the board of directors of the Louisiana Healthcare Quality Forum and served as a member of the AMA's Minority Affairs Section Governing Board. Dr. Weather is a graduate of Howard University College of Pharmacy. He received an MD degree from Rush Medical College in Chicago and completed his residency and fellowship in obstetrics and gynecology at the Johns Hopkins University Hospital. And finally, we have Dr. Currie, is a physician member, as I mentioned, of the Washington Medical Commission and is the medical director of the Quality and Care Transformation for Providence Medical Group in Southwestern Washington. She is on the faculty at the University of Washington Family Medicine Residency Program, based at St. Peter's Hospital in Olympia, Washington. She joined the Washington State Medical Commission in June of 2019 and is the chair of the Commission's Health Disparities Work Group. Dr. Currie has a bachelor's degree in computer science and philosophy from UC Berkeley, University of California. While working in the Bay Area in the 1980s, she also volunteered at the Haight-Ashbury Free Medical Clinic in San Francisco. Her experience working there during the HIV/AIDS epidemic influenced her decision to pursue medicine as a career. She attended Harvard Medical School, where she became interested in reproductive endocrinology and women's health, and later transgender hormone management. She began treating gender nonconforming and transgender patients in 2000, long before there was a national spotlight on transgender people. As a commissioner and educator and as a frontline clinician, she advocates for equitable delivery of safe, high-quality healthcare for all people. Welcome to all of our distinguished panelists. We will, as I said, begin by giving each of our panelists 5 minutes to provide some introductory thoughts on our symposium topic and our speakers before we engage in discussion. We'll begin with Dr. Maybank. Hi, Aletha.
Hi, how are you doing, Hank? And great to be here. Great to see you and to be in
Likewise.
conversation, and great to be with this wonderful panel today. And I'm really thankful that you all are convening and having this conversation explicitly. I think we are now at a time, as has been said many times, that COVID has definitely exposed the inequities that have been here for really centuries in this country and on this land. And other events such as the public murder of George Floyd, the recent death of Susan Moore, who's a physician who passed away from COVID, just really highlights that racism is present. We have seen many organizations, whether they're healthcare organizations, we've seen government, we see our now new administration calling out racial equity and the need to have racial equity and strategy and program and policy throughout all of government. So we're in a very important moment that I think is going to be absolutely critical for us to capitalize on and operate with a sense of urgency. We need to be strategic and we need to be thoughtful. The evidence is there that these inequities exist. The evidence is there in terms of root causes around the forms of oppression and racism even more explicitly. I think now is the time for commitments by institutions, naming these inequities and naming the fundamental causes such as racism, but then also figuring out what are they going to do to hold themselves accountable to doing this work. I think that's the risk that we have right now, that we see many organizations putting forward racism pledges or anti-racism pledges, but they haven't really thought through the accountability of doing this. And I don't think organizations really fully understand what it means to operate with a sense of anti-racism or to put those systems and structures in place. So I think that we're at a moment again where we have to make the commitment, but we have to do action at the same time. And then we do have to evaluate and measure that action as well. But I think accountability and the commitment to doing what we said we're going to do is what's going to be really important for right now and for this time to really move the equity agenda forward. I feel we've been stalled for a long time. We've named the disparities. There's lots of evidence. There's lots of data on the disparities. But really digging into the root causes, how they show up in our day-to-day systems and organizations is the important work at this time. And what are we going to do as individuals and the collective to actually change that is our question right now. Thank you.
Thank you very much, Dr. Maybank. We'll next hear from Dr. Weather. Good afternoon.
Good afternoon. First, I'd like to take this opportunity to thank you, Dr. Chaudhry, and Dr. Walker-McGill, along with the FSMB members and staff, for putting a spotlight on implicit bias and inequity. For through the years, I can attest to the countless number of individuals, their tsunamis, their discombobulations, and enormous buckets of tears relevant to the trials and tribulations of those who, writ large, were the victims of implicit bias and inequity. To ease the pain, as many others have provided hugs, comfort, guidance, support, and love. Beyond this, one of my patients stated a few months ago that what she was going through, in essence, was indeed racism. And that experience was magnified as she communicated with her daughter. So in turn, the daughter's rejoinder or reply in terms of what her mother was going through is that she stated, "Mommy, if everyone was treated like Black people are treated, then everyone would start treating everyone better." My impression of the current health equity environment is that it's problematic, for some of the past gains were stifled or rescinded. This is due, in essence, to the local, state, and national policies. For example, the Executive Order 13950, combating race and sex stereotyping, which was signed again by the former administration. And this, in essence, prohibited unconscious or implicit training, bias training. The chilling effects of this executive order on the collective efforts to advance our nation's public health has been swift and alarming. In regards to the trends, I believe they will be more favorable or auspicious. For example, the current administration's January 20th, 2021 executive order on advancing race, equity, and support for underserved communities through the federal government is a prodigious boost to redressing the pain. Now, I'll speak about the NMA initiatives and its leadership role in addressing these issues. First, the NMA is the conscience of medicine and is the nation's oldest and largest organization representing African American and health professionals in the United States. Established in 1895, the NMA is a collective voice of more than 50,000 African American physicians and the patients they serve. The NMA was founded in 1895 during the era in the U.S. history when the majority of African Americans were disenfranchised. The segregated policy of separate but equal dictated virtually every aspect of society. Racially exclusive Jim Crow laws dominated employment, housing, transportation, recreation, education, and medicine. Black Americans were subjected to all of the injustices inherent in a dual medical care system. The National Medical Association, as stated, has historically advocated for health equity and cogently addressed implicit bias. The various aspects of this are via our local, state, society, and regional educational meetings. In addition, concretized in our national programs, colloquium, annual meetings, and the community outreach programs. In fact, the NMA is one of the founding members of the Black Coalition Against COVID. The coalition has met with the CDC and Biden-Harris transition team over the past several weeks. Recently, the NMA was involved in discussions concerning COVID-19 vaccine dissemination, equity, and social determinants of health. Aside from this, advisory statement on the FDA emergency use authorization approval for Pfizer and Moderna vaccine, NMA and AAMC Action Collaborative for Black Men in Medicine, the Anti-Racism in Public Health Act of 2020, the NMA and the Congressional Black Caucus Professional Development Collaborative Series. And we have a wealth of others. However, I'll stop here. Thank you.
Appreciate you also mentioning the NMA. It's certainly been an organization that's been in the news and has been active in advocacy in the last few years. And Dr. McDougall, whom we know at the FSMB, has been active as its president. Finally,
and
we'll
superb.
hear from Dr. And superb, yes. Finally, we'll hear some opening remarks from Dr. Currie. Good afternoon.
Thank you.
Good afternoon, everybody. It's my honor to represent the Washington State Medical Commission today and to describe for you some of the work that we're doing in the realm of health equity. So first, I want to set the stage. 29 years ago, when I was a medical student, I read an article in the Boston Globe that launched me down the path that leads here today. The newspaper article described the vast differences in the infant mortality rate based on neighborhood of where the mother lived in Boston. And just south of Huntington Avenue, which is one of the main thoroughfares, the Green Line, the T, in Boston, a few hundred yards away from Harvard Medical School, the infant mortality rate was 3 times higher than on the other side of that street. This statistic was as infuriating then as it is now, and as a budding OBGYN, it spurred me to want to understand and to help. So I applied for a grant to study and work in the underserved areas of Boston. My funding came from the Albert Schweitzer Fellowship, named for the Nobel Prize-winning humanitarian and physician, and its mission was to prepare professionals to serve and empower vulnerable people to live healthier lives and create healthier communities. Coming full circle, I want to share a quote with you from Albert Schweitzer. Example is not the main thing in influencing others. It is the only thing. We at the Washington Medical Commission have taken this to heart. And in order to lead by example, we've embarked on a series of projects that look inward at ourselves as a commission and also outward to our communities and our duty as a regulatory body. So let me describe some of our inward-facing work. In August of 2019, the Medical Commission staff, the investigators, attorneys, everybody, underwent implicit bias training to raise awareness around the effect of unconscious bias in our everyday work. We also created the Health Equity Advisory Committee, whose goal is to review, through the lens of health equity and implicit bias, all of the administrative policies, procedures, and practices that govern the Commission. We also solicited stakeholder and community input. This work has led to many changes, but for the sake of time, I'll just name a couple. So for all of our case reviews that we do every week for the complaints that come into the Commission, we have now removed any identifying information about the respondent, including age, sex, whether they're foreign trained, board certified, etc., because we recognize that these factors are commonly contributing to implicit bias. Another example is we've changed the sexual misconduct and abuse guideline by replacing the gender-specific pronouns with they, them to make the guideline more inclusive. Regarding specific activities for the commissioners, we have undergone a 2-part workshop on implicit bias. And we've all done the Harvard online implicit bias test and brought our learnings back to the Commission to talk to each other about what we found. And actually just had our 2nd workshop a couple of weeks ago. The workshops were very powerful educational sessions. We really learned how to examine our own implicit bias and our explicit biases, and understand how they might affect our work as commissioners. At times, it was an uncomfortable process, but it's necessary in order to bring our best selves to our work. We've also created the Health Disparity Work Group, of which I'm the chair, and our charter reflects that to promote wellness and health equity, we need to address the upstream factors that influence health. It's recognized that physicians must inform their treatment plan based on the social determinants of health, and not just the disease or the diagnosis. And we actually applaud big time the recent CMS E&M coding changes that acknowledge that the social determinants of health are a significant factor contributing to the complexity of care. We recognize that addressing all the upstream factors may be beyond our scope, but we have an obligation and an opportunity to impact physicians and physician assistants under our jurisdiction. As with all medical boards, we want to promote patient safety and enhance the integrity of our profession. So moving to some of our outward-facing activities, using the tools at our disposal, which are essentially licensing and education. We have held annual CME conferences, and last year in 2019, 2 years ago, I guess, we had the theme of healthcare's role in affecting social change. We had speakers addressing many aspects of the health equity landscape. For example, on the challenges of practicing medicine in rural and underserved areas, challenges facing American Indians and Alaska Natives, how to do community health needs assessments and partner with community organizations, and on a subject that turns out to be very relevant this year, how to communicate with vaccine hesitant patients. Because of the pandemic, we haven't been able to have our conference this year, but we have continued to provide free CME webinars highlighting various aspects of health equity. For example, I recently gave a webinar in my area of expertise on addressing the healthcare needs of the LGBTQ community. I'm also excited to report that we are working closely with our state legislature to pass a bill that would require every licensee in our state to take a set number of CME hours dedicated to understanding the social determinants of health, systemic racism, and implicit bias. We feel that this type of direction is within the scope of medical regulation, and it meets the mission of protecting the public and reducing patient harm. I wish I could say that in the decades since I wrote that Schweitzer grant, things have changed and that the infant mortality rate is no longer tied to neighborhoods. But unfortunately, we haven't made much progress, and there is still so much to do. Of course, we can't do it by ourselves. This is a complex and complicated situation. We acknowledge the necessity of partnering with community organizations, our state medical association, national associations, and others in an effort to examine the data, acknowledge the impact of systemic racism and implicit bias, take actions, and really carry out the mission of protecting the public, all of the public, and ensuring that our licensees are providing the highest level of medical care for all of our communities. Thank you.
Thank you very much, Dr. Currie. And thank you also for sharing the good work of the Washington Medical Commission. Just as Dr. Weather also spoke about the Louisiana State Board of Medical Examiners, the state boards are doing what they can, and we have many of them on the line today on this webinar, and I think they'll be eager to have this discussion. So let me go into that phase now. We're going to spend about a half an hour chatting, and then we'll open it up to questions for the audience. Each of you spoke very succinctly and movingly on things like accountability. Dr. Maybank spoke about, Dr. Weather spoke about injustice, and Dr. Currie spoke about the importance of example. And I think those are very key points, and I appreciate that. Marc Morial, earlier this afternoon, in his inspiring remarks, made a profound comment that I'd like for you to reflect upon. He said that I trust when people have the right information that they'll make the right decision. When you think about those who manage healthcare, those who provide healthcare, doctors, nurses, pharmacists, when you think about those who receive care and those who regulate healthcare, whether through licensing or discipline, do we have the right information? And this is for all of you. Any one of you can start.
Well, I'll start. I actually think that having the right information is the minimum, and it's necessary, but it is in no way sufficient for patients to make the right decision. Time and time again, we have strived to sort of provide shared decision-making tools and pamphlets in the right language and culturally appropriate and all of that with patients. But honestly, hearing it from somebody that they trust is much more powerful than hearing it from a doctor, even though the doctor's words might or content might be more accurate. So that interpersonal communication and that trust in the person that they're hearing it from absolutely overshadows the right information. And I think we've seen that time and time again. I know in clinical practice we do every day.
Thank you, Dr. Currie.
Yeah, I mean, I agree with that. And just to build a little bit on it, I think we're in a time that shows that if folks have the right information, it doesn't mean they're going to do the thing that we want them to do as the profession per se, that is optimal potentially for their health. And and I think for us, I think the imperative as institutions and leaders within these institutions that are here to serve people and protect their health is to understand why that gap exists. I think it's a really strong assumption to make that if somebody has the right information, they'll make the right decision. And in the context of doing the equity work, and what's many people are talking about, and somebody mentioned, I think in the session before, is the lack of trust that exists. So even if folks have the right information, it doesn't mean that they are going to believe or they're going to trust. And there are many long-standing occurrences and recent occurrences that they may have experienced themselves or their families have experienced that set up a situation that there is a lack of trust. And the reality is that we have to, I am very much rooted in talking about anti-racism. The American Medical Association this past fall put forward 3 policies: one to name racism as a public health issue, one to rid the healthcare system of race essentialism, and really recognizing that race is a social construct, a biological one. And then the third one is to rid medicine of using race as a proxy for ancestry and biology, et cetera. So to me, we're really talking about the experience for Black and Brown communities that we've been talking about a lot, especially during the COVID, who are experiencing greater numbers. We are talking about their experience of racism and the impact of racism. That's the situation that has set up a lack of trust. And so we have to address that root cause. And then we have to really frame it as a lack of trustworthiness on the part of the institution. And what do institutions need to do? I think the frame of saying give the patient the right information, they do make the right decision, that is putting the onus of responsibility so much on the patient and not enough on the institution to figure out what they need to put in place to make sure that patients are well informed. There's the space of shared decision making that was already mentioned before, so that they feel like and they know that they are making the best decisions for their own health.
So my take on that is that just because the right information is presented doesn't always impart that the patient or anyone else for that matter is going to do the right thing. So that's what's expected. But then we have these outside influences, I would submit, that certainly play a significant part in regards to what we do and how we do it. For example, looking at social media, looking at the various patients, if you will, or others that explicitly know and have heard what's going on with the pandemic. It's devastating. But in many instances, you'll find people who talk about the precariousness of the vaccine, But then at the same time, they have mother or family member at home who's just got out of the hospital, or unfortunately have expired. So what it amounts to, in essence, is that there's outside influencers. There's the stressors of life. There's work. There's school, and there's friends. So it really impacts how we actually manage the information that we have. And in many instances, we have that information, we accept it, but it's not really utilized to the best interest of the individual that has that information.
So thank you. And each of you spoke about, it's not just the information. Sometimes it's also the person delivering the message. And I think Dr. Currie alluded to that. Help me understand and help our audience understand the relationship between having diversity in the health professions themselves, whether medicine, nursing, or pharmacy, or the others, and the ability to deliver equitable care. How important is that, and what can medical boards and medical regulators do to impact that?
Well, we know the data and evidence, it only increases and mounts that race concordance, or a patient physician or whomever that is absolutely important and critical to patient satisfaction. That's what the evidence shows, as well as greater evidence about patient outcomes is also improved based on race concordance and being of the same race and ethnicity. So that means, at the root of it, that, it is imperative that we make strong efforts to have increased diversity and representation throughout all of the health professions that exist in order to help support kind of trust in the messenger. Is that how it absolutely should be and have to be? Absolutely, no, we don't want to have to go that direction, but that is what the evidence is telling us and where it's guiding us. And so then the question, I think, goes to, so what's happening that we are excluding people of color? I'm going to go to race and ethnicity, especially in the physician population, where the numbers are still just tremendously low for Black, Latinx, and Native American communities. I mean, it should really be an outrage at this point in time in terms of the lack of diversity. And so where is this exclusion happening? Why is it still happening? And so there are plenty of efforts, NMA leading many of these efforts for years about diversity and what we need to do, AAMC, and we still have made little dent, I think, as has been called out before. And we recognize that there are challenges at the entry into med school, but there's also challenges related to pipeline, because these issues are broader than just what happens in the context of the school setting, right? They're structural. They impact education, they impact housing where people live, they impact access to what students and families have in terms of finances. We know the tremendous racial wealth gap in this country also impacts the ability to have access to so many different opportunities within this country. All these things impact diversity. And I think when we get to kind of the solutions, again, we have to be able to better look at our own structures, our own policies, look at our own data, and see what is happening. So when I think about the individual, whether it's the medical society or the board at the state levels, what is your own data showing you? And just to follow that data and look at that data, disaggregate your data, because not everybody's doing that. People say they are, but what we've noticed, not everybody's disaggregating their data to understand what's happening at race and ethnicity. And then do some assessments of members, do some focus grouping, do some qualitative assessments to find out what is really happening, and not making assumptions about why there is a lack of diversity. And then I think that usually gets you more so to what are the policies and the structures and the systems that are set up that are actually creating that exclusion. But we have to do that deep dive. We have to have that curiosity. We have to care enough to do it. It's hard, because oftentimes you're going to start seeing yourselves in ways that you didn't want to have to see yourselves, or you didn't want to have to face up to, which may be embarrassing, or for some reason portray a message as if you don't care and it's bad intention. But that's not the case. If we really are meaningful about the work of equity, then we will dig into our own systems and understand our own numbers and dig into our history. I think about the AMA. And the reality is, we have contributed to the exclusion of Black and brown physicians within medicine. And it may exist because of the exclusion of Black physicians from the AMA. And that exclusion prevented physicians from getting privileges in hospitals. So it's not just we excluded Black physicians, we prevented the ability for Black physicians to practice when we already knew there were setups of segregation, as was mentioned earlier. So then what happens to the families of these communities? So, there's such a trickle effect to all of this. And we have to be able to kind of name, claim, and then figure out what are the impacts and then what are we going to do about it.
So that's a great point, Dr. Maybank. And let me ask Dr. Weather and Dr. Currie to reflect on the possible role that state medical boards can play to help to address that, because there are challenges, structural challenges, if you will, that are built into the system. State medical boards don't control every element of that pathway, Dr. Maybank, that you alluded to, the pipeline, the continuum of medical education. What role do state medical boards play, and what role can they play? Dr. Currie first, and then Dr. Weather.
So I think that their role, as you said, is somewhat limited, but it's not zero. There are things that we can do. And certainly the amount of money that it takes to go to medical school and the mentoring that it takes excludes right there just so many people. So one of the things we've thought of is to have sort of a clearinghouse, if you will. We are the state licensing body, so we know who's active in our state. Getting people who are semi-retired to become mentors, matching up medical students or pre-med students, residents with mentors, hopefully people that might look like them and come from backgrounds similar to theirs. That type of support and connection can be very powerful. Anything we can do to ease the way for people who have historically had just these massive barriers is everything that we should do. That's what we should do.
Thank you. Dr. Weather,
Yes.
do you agree?
Categorically, I do. And in fact, I think as we look at this, it's really important for us, and it's monumental, if you will, for us to be able to anatomize the data. It gives us, in essence, the truth. It helps and guides us in terms of what we should do and how we should do it. I think in the past, we've really failed to acknowledge, we've had this, I guess you could say, altruistic dearthness or rectitudinous blindness where we have not seen what we should see. So it's important for the boards. The boards certainly do have some weight and gravity to be able to assist, but obviously the boards cannot do it alone. We need a total comprehensive involvement, number of players in order to be able to get this right. But the first item of business is to make sure we acknowledge it exists, not ignore it. And we need to, in essence, do something. And we have the power, the wherewithal to do it. And I think going forward, as we look at this new administration, I think they are on the right track to be able to do the right thing.
Thank you. Let me ask a question, first of all, for all three of you, and then a follow-up question to our two regulators, Dr. Currie and Dr. Weather. The broad question for each of you, and maybe we'll start with Dr. Maybank on that one as well, is should there be more explicit language about health equity in state medical board regulations as it relates to healthcare? So an open-ended, broad question about language, laws, regulations, procedures, and policies. Dr. Maybank, start with you.
Yeah, I'll start with the broad view of it. So yes, and I think as Dr. Weathers just mentioned, I mean, you have to be able. If we don't name it, we're not really fully claiming it, and I think it's hard to measure. What are you measuring if we're not naming it, and what are we going to be assessing if we're not naming explicitly equity, but also the foundations of where inequities come from, and so. We've been working a lot, and I've worked a lot over the years with groups like Race Forward, Racial Equity Institute, that really talk a lot about the importance of being race explicit or equity explicit, So when you're creating goals and programs and performance measures and metrics, and all of us do that they need to be equity explicit. And we need to be in our mission statements, in our values. They need to incorporate values of equity and equity principles. Really rooted in valuing, all people equally is a basic one. But we need to say that, we need to be explicit about it, because if we're not, then we're not really fully committed to it.
Thank you. Dr. Weather?
Yeah, absolutely. And I think this certainly has to be done in concert with the legislators. There's many things that can be done together, and oftentimes we may try to do the things we'd like to do, but then we have pushback, or we don't have that buy-in from some of the legislators. So we not only do we have to walk and chew gum, we've got to make sure in this regard that we do get the legislation, at least to inform them, to make it clear and explicit to them, to make sure our staff has buy-in with this, to give them the information that what's going on. So that involves cultural competence. It involves a number of different other areas, which certainly takes time, finances, and also beyond that, it takes a cogent commitment.
Thank you. Dr. Currie?
Yeah, I think we absolutely have to call out race, gender, ethnicity, language, all of the things that makes us all different. All of those things need to be embraced and really highlighted, brought into focus. For too long, people just want to work with the people that make them feel comfortable, which is always someone who you are familiar with, right? That's the whole point of implicit bias and understanding that. So we need to get explicit. We need to call it all out and put it out there. And it does make some people uncomfortable sometimes, but it's important work to do. And I think it's really the only way we're going to make strides forward. So we do need to look at all of our laws and our practices, our procedures and policies. And at the Washington Medical Commission, we've been doing that. And we have discovered so many places where sort of it just creeps in insidiously, race, sex, whatever, how old a person is, where they come from, their background, all these things, and they influence decisions that get made. And so it can't be allowed to sneak in. It has to be called out and brought into the light.
Absolutely, Dr. Currie. You reminded me of, actually, I think in Dr. Weather's remarks, he mentioned implicit bias. I know of at least one state medical board, aside from yours in Washington, Dr. Currie, the North Carolina Medical Board, that is doing a study to look at the disciplinary actions that have been taken by the board over a period of time to see if there's implicit bias and to see if that bias potentially could be minimized, if not eliminated, by blocking those kinds of things out: age, gender, sexual orientation, specialty certification, even ethnicity, race, and to see if the disciplinary actions that are taken could be different. So it is an area I'm happy to report that the state boards are working on. I guess a more challenging question, and this is for Dr. Currie and Dr. Weather, is when does inequitable care, if ever, become a disciplinary issue? You're both involved in licensing, you're both involved in disciplining. How does inequitable care, it's one thing to say that everyone should strive for equitable care, but when you see evidence of inequitable care, when and how does that become a disciplinary issue? Not an easy question.
Yeah, we struggle with this, and we've had many cases that highlight this issue. I think that I'm just going to call it out there. There are lots of excuses why somebody doesn't want to see a patient. We've had doctors who had complaints against them, for example, from transgender patients who felt they were being discriminated against because they were transgender. And then you go look at the records, and it's really hard to find that one clue that says, well, yes, this doctor didn't want to see the patient because they were transgender. The doctor will write something like, oh, I don't think that this is something that I can deal with. It's not in my scope. Or, for example, We have a lot of private practices. Let's just call this out: fee for service, time is money. If you have to have a translator for, say, a Vietnamese speaking patient, that appointment might take twice as long. So there are very subtle but pervasive ways that practices might sort of scoot the non-English speaking patients away from their practice because they're not as cost effective. So there are lots of subtle ways that this comes out. As a regulatory body that really has the tools of sort of restricting licenses and putting informal dispositions on licensees or suspending their license, I mean, those are fairly large hammers to wield, and you have to have pretty strong evidence that somebody's doing the wrong thing before you're going to wield one of those hammers on them, right? So you have to be a little bit cognizant of the fact that, you're careful not to overreact. But many is the time that the commissioners sit around reviewing a case and thinking, could we just send them a letter saying, knock it off? What you're doing is not okay. It's not right. It maybe doesn't rise to the letter of, breaking the code, but it's something that comes up. Yeah.
And people don't realize outside of medical regulations, sometimes those letters of reprimand, even a phone call, can be effective and they do what's needed. Sometimes, but as you say, a hammer is needed. Dr. Weather?
Right. So, yeah, you're absolutely right. Sometimes it certainly needs to be a hammer. But I would submit that it's important for us to understand about patient safety, and implicit bias does impact patient safety. It causes major issues. But I would also talk about the fact that it's difficult in many instances to prove it. But if in fact we are able to prove the show, then it needs to be redressed, and that certainly should be considered in the realm or what we would call unprofessional behavior. So it's important for us to do. It's important to make sure that our members are aware, not so much that we're looking at you, but we're wanting to partner or to help or to inform to be able to not only get the message out, because I'm not really cognizant of the fact that we've done a great job throughout the country with almost every aspect, not particularly medical boards, but with almost every aspect of what we're dealing with. And so now is the time for us to do something. And I think going forward, we need to certainly embrace and inform, educate, provide various means for us to be able to to get it right. And in that regard, letting the members understand, providing a means for them during their relicensure. They have to have certain programs, or whether it's cultural competence, or whether we're talking about other different entities, but we have to be able to get the word out, whether it's our websites or whether it's videos or PowerPoints, not only they, but also the staff at the various state departments.
Thank you, Dr. Weather. You reminded me, though, that it also works the other way around. And let me ask you, as a past leader of the National Medical Association, and Dr. Maybank, as a current leader of the AMA, right. We've also seen examples where patients will not want to be taken care of by whether it's Black, Brown, Muslim, Jewish, or Hindu doctors. And that becomes an awkward situation in the healthcare setting. How do organizations like the AMA and the NMA address those kinds of situations?
Yeah, frankly, it's about informing, about knowledge, education. Of course, trained at Hopkins, and I would kind of give you a little story. One day I had an intern, of course, at Hopkins. I think it was sometimes a week before we were able to leave the hospital as an intern. So we had to do everything. Those days, draw blood, do whatever else. And so we had this patient who was from Texas, and basically the patient did not want me to take care of her. I don't want you to take care of me. So I was able to kind of speak to her and to kind of get it straightened out. And the doctor was Dr. Jones, Dr. Howard Jones, which is, just a giant. So long story short, I was able to talk to her and was able to be able to not only communicate, but at later stages or later days, the only doctor she wanted to see was me. So in NMA, it's really about education, providing information, letting people know that we're one, we're all alike. It's about understanding, it's about rendering the best we can get. It's about getting the patients who need assistance. It's about making sure that everyone understands in this great country that we all need to be together. We should not be hating. We should not be causing problems. We as physicians, practitioners, the NMA in particular, has always been about what is right for our patients. And it doesn't really matter how the patient looks. It doesn't matter whether she is Black, white, Asian, or what have you. It's about taking care. It's about our calling. It's about doing the right thing.
Well said, Dr. Weather. I mean, I remember,
Thank you.
I went to medical school in New York and did my training in Long Island and in New York City, and always was impressed with how the focus in healthcare, perhaps more so than in other professions, was on the meritocracy of it all. That if you did well, that's what seemed to matter. But we do know these other kinds of examples exist. Dr.
Right.
Maybank, your thoughts?
Yes, I think, well, I'm in agreement. I think there is an education piece to it, to the patient population, but I think it's part of the culture that institution again is kind of putting forward, and expressing early on in whatever form they need to do so, that there is not a tolerance for any type of discrimination within the context of the healthcare space, whether from the patient or the physician. And I feel that it's the education, but there has to be policy around it. There has to be structures around it, and then there has to be systems in place that allow for conflict management, for if something arises and there's a system in place to help address whatever problem may elevate down the line. Systems need that support. So I think we have to move a little bit beyond the education components of it and really make sure it is the response to when these incidences happen is also built into the system as well. I think that's absolutely critical. And I think COVID really shined a light on some of that early on, with a lot of the stereotyping that was happening towards Asian physicians in the healthcare setting. And we heard many complaints through several systems of the experience, and also in talking to the physicians, Asian Pacific Island physician group, of all the things that they were experiencing, the discrimination, the attacks, and the naming calling. And there had to be statements, and I think if many people remember, there were statements that were put out by those institutions to say that we would not tolerate this, and we will not tolerate discrimination towards our providers and our physicians. And if so, then something, there could be repercussions for that. So I think it's really important to name it, though, as well, and again, build it into our systems in terms of response and accountability to that.
Thank you, Dr. Maybank. Powerful words. I want to make sure we leave time for questions from our audience, but let me ask one more question, and it's an easy one, I think. You can answer yes or no. So we'll start with Dr. Maybank, then Dr. Weather, and finish with Dr. Currie in the order in which you gave your remarks. To get us to where we need to get to as a society and as a country, should state medical boards be working more with the organizations that represent physicians, the AMA, the AOA, the NMA, the Council of Medical Specialty Societies, for example? Dr. Maybank?
One word, I'll just say yes, to keep it simple. I mean, but I think what COVID shows is the importance that we do need to work together. I think that's been a really helpful opportunity within the context of COVID. We are working in ways with people that I don't think we had we just weren't working with as much. It is definitely broken down silos, which tends to happen in a time of emergency anyway, right? That's what emergency response is about. However, we need to keep that up. And we need to keep that engagement up and pursuit to find solutions that are not in silos and that are not segregated from other ideas that people may have, because we're so interdependent.
Thank you. Dr. Weather and Dr. Currie, do you agree? Because in medical regulation, we do have a tendency to keep a sort of arm's length because we represent the public, we look out for the public, but that doesn't mean we
Sure.
can't have conversations and work together.
Right. So I would say yes and yes, because it's essential that it takes us, it takes all of us really to land the plane. It takes the crew, it takes the pilot. So collaboration is absolutely, and I'll, with a bullet, not only with the underline and bold parentheses, it's in italics. It's really important for that to occur. The boards, in essence, does have the wherewithal. One has to be able to get his or her license, and I think in that regard, we can certainly get their attention and perhaps be able to make things better sooner than otherwise.
Thank you. Dr. Currie?
Well, the answer, of course, is yes. We do all have to work together. And I would just say that from where I stand as an educator, I've been teaching residents for 25 years. Medical education and residency education is another place where we have to collaborate. We all have to work together. And you're right, regulatory bodies like the licensing boards do tend to be a little bit standoffish and siloed. We're sort of the public protector, but also the bad guy when it comes to licensing and disciplining physicians. But in essence, we are the voice of the public. We work for public safety. And for better public safety, we need more doctors, more collaboration, nurses, emergency medical techs, whoever, to work with us to get better access for all of the public so that we can reach all of the public.
Great. Thank you so much. Let's go to the questions from our audience. And as you can imagine, we have quite a few, so we're limited for time, but let me pick out the ones that speak to all three of you. So one of the questions we have from our audience is, if state medical boards were to mandate healthcare equity education for their own board members so they can be more informed about things like implicit bias and do the right thing, what are the parameters to assess whether it is effective or not? Maybe that's a question to start off with Dr. Maybank and then Dr. Currie and Dr. Weather.
That's actually a really critical and important question, and a question that gets asked oftentimes. I think we still have a lot to do in terms of the evaluation of the impact of trainings. What we do know that the evidence shows that trainings alone typically are not enough. They may help support shifting slight critical consciousness. So when I say trainings, I'm not just talking about cultural competence either, nor just implicit bias. I usually take away the word implicit bias and then training around kind of system structures, equity, racism. Like that's what people need: structural competencies, understanding the influence of structures on our day-to-day decisions. So I just wanted to kind of state that first, that I think we do need to evolve in how we talk about what is important in terms of training. But what we know is that a lot of this has to be contextualized into, so what else is that system doing? What else are the boards doing to look at embedding equity through their practices and policies and changing culture? Because oftentimes what can happen is we can train folks, but if that culture is not set up to adjust to this new training, this newfound knowledge, this new way of doing things and thinking things and way of acting, then that's just going to cause a rift potentially and further conflict. So there are many modalities within the boards or other organizations that have to be operating to the point of making equity actually seen and heard and visible within that institution. It's not just the one-off training. It's important. It's critical. But we need more aspects happening at the same time because the evidence doesn't support it. And we don't have enough evidence to really demonstrate the full impact yet of what these trainings can do. But we're on that direction and path to do so.
Thank you. Dr. Weather?
Yes, certainly I concur that we further need to make sure that we have our work groups, advisory panels. We need to be able to not only evaluate today, but we need to look at tomorrow. And that comes certainly in concert with us being able to view what our actions were, and then taking those actions, looking at not only the various other forms of training, videos, websites, and so forth. That needs to be put in one bucket. But then on the other hand, we need to go forward and 6 months down the road to see what's the impact, what our analysis showed in regards to where we were, the number of cases, the number of different items that took place. All of that needs to be involved and put in this second bucket to be able to see if we can get the third bucket, and that third bucket being able to make sure we have a better outcome.
Thank you. Dr. Currie?
So we've done this work in Washington. We've had our trainings, and I couldn't agree more that training isn't enough. You have to take it to the next step. And what's very interesting is, well, first of all, you have to do the training, you have to raise the awareness. But once you do take it to the next step and you start looking at every little policy and practice and what you do on a day-to-day basis, you kind of go deeper and deeper and discover more and more the opportunities for bias to sneak in. And so just having an iterative process of going through it, implementing the changes, redacting all of the information that could lead you down the path towards bias from every form, from every hiring practice, from every decision. It's hard work and it's detailed work, but it really needs to be done. And we've had some interesting findings where we will present a case, and in the old days before we did this training and sort of cleaned up our act, we might present a case from a complainant that was from the Department of Corrections, and you could go around the room and see people sort of roll their eyes and think, oh, we always hear from this person, blah blah blah, and then you present the exact same case, the same facts, but you leave out that this was a Department of Corrections complainant, and it's a very different outcome. So it's really helpful to sort of pin people down in those very specific ways and get them to feel it at a visceral level. And then that gives them the energy and spurs them on to make the changes in their work, in the day-to-day practice. I think that we also really have to raise awareness and have visibility within the boards for our own diversity. So we do a lot on our boards of looking at the nursing board and the DO board and the MD board and seeing who makes us, who are we? And do we reflect the Washington State physician composition or population composition? And sort of keeping an eye on that, measuring that, and moving the needle towards a more accurate representation.
Dr. Currie, you anticipated the next question I was going to read from the audience, actually. And this will be our final question. They begin with a statement. Thanks for an outstanding and thought-provoking discussion. Do you support, and maybe this is for Dr. Weather and Dr. Currie in particular, do you support mandates for diverse representation in board appointments? And what metrics should be employed in meeting this goal? Of course, recognizing that this is not something that state boards completely control. These are often gubernatorial appointments. But what are your thoughts, beginning with Dr. Weather and then Dr. Currie?
Yeah, I wholeheartedly support that. I think it's important. I mean, there's some boards that may not, well, let me give you a good example. There's some boards that may not actually have diversity. But fortunately, the great state of Louisiana does in fact have it. It's mandated that a member of the National Medical Association, 2 members of the National Medical Association, be on the board of medical examiners. So we're kind of ahead of the game, and it's been working certainly superbly to be able to help. And I think it has been very impactful and has been able to allow the people in the great state of Louisiana to have better outcomes because we're able to have more involvement. And if it weren't for that, for that legislation, then it, quite frankly, it may not be the case that we would have, because these are, in many instances, government appointments, and it may be that we don't have the political weight to be able to get that. But it's legislated; it's a part of the law, and I think that really goes a long way. And I think going forward, that is one of the more affable ways of doing this. It may not be the only way, but I think certainly, and frankly, that is one of the ways to be able to help make things better for the people in this great state of Louisiana and throughout the country.
Thank you. Dr. Currie?
Yeah, Whether you want to make it mandated in law is a question maybe for legislatures. We know that for medical board members, we are appointed by the governor. We are sort of recruited from throughout the state. We have people from all of the different like congressional districts. And I want to just go back to a concept in medicine that we are sort of a self-regulated body, right? So doctors sort of regulate themselves. Hospital quality review committees regulate themselves. We sort of keep an eye on each other to keep things in check. We don't want to wait until things are sort of so out of balance that it requires an outside force to mandate or legislate our way back to the right place. So I would just say that coming from the Washington board, where we have really taken this into consideration and tried very hard to find representation across the board, whether it's gender or race or ethnicity or location where people are from. If we can really put our eyes on that and make strides towards that without needing the legislation, that would be the ideal.
Thank you, Dr. Currie. I'm going to give the last word to Dr. Maybank. One of the things she taught me 15 years ago, she taught me a lot about equity and inclusion. But one of the things she said was, it's not enough to have the right people at the table, although it is a good first step. Dr. Maybank, your thoughts?
Right. Thanks for that. Yes, and it's still true. You know, it's the difference between diversity, inclusion, and equity, right? You know, I think having different voices are absolutely critical. To have different ideas, I think it's key for innovation. Inclusion is saying that these voices are present and they're able to participate kind of in the conversation. And, you know, equity is more so getting to a redistribution of power. So now these voices actually have the opportunity to have decision-making power, you know, and be at the table. And to Dr. Weather's point of the example of NMA and the representation of two people, or legislation of two people who are from the NMA to be part of that conversation, that's critical. That to me is a demonstration of what equity begins to look like. And then I think we have to take it one step further now, and it's really talking about justice and making sure that always that those voices that are most marginalized, so the physicians that are most marginalized, the physicians that may, and I think this is where looking at data becomes very important, that may have come up with the data but having more issues, need to be centralized in terms of their conversation. They need to be centered in terms of figuring out what are the solutions in order to create equity. And so we know physicians of color, patients of color, have the worst health outcomes, and they experience the greatest context as it relates into injustice. And that means we need to center those voices, and that's the context of justice. And so all of those are absolutely critical for us to get to an equitable society. But it has to be intentional. It doesn't just happen. I am a believer that we have to have accountability. You've heard me say that over and over, with ourselves and amongst each other. I don't believe that things just happen for the good of it. We've done that for a long time to create expectations that, you know, well, you know, it will work out. You know, people will self-regulate to a certain degree, but we get at this point in time that hasn't happened in the space of diversity, equity, and inclusion. So accountability, intention are absolutely critical to get to those different aspects of equity and justice.
Thank you very much, Dr. Maybank, Dr. Weather, Dr. Currie. You've given us a lot to think about. Thank you to our audience who listened in and gave some very good questions. Let me turn it back to Dr. Walker-McGill to make some closing remarks. Thank you all to the panelists.
Thank you. Thank you.
Thank you, Dr. Chaudhry. And thank you, panelists, for an outstanding discussion. We have now reached the end of our symposium. For several hours, we have focused our attention intently on an issue with major impact on the quality of healthcare in the United States. I hope each of you feels enlightened by what we have heard today during our discussions. The question now is, what will each of us do moving forward? My fervent hope is that you will view this event as a beginning, a starting point for your own journey to think about health inequities and disparities in a new light. Each of us has the power to do something about this issue, to make quality health care accessible to all Americans, and to even the playing field so that health outcomes are truly equitable, regardless of race or background. For those of you who represent state medical boards, this is an opportunity to go back to your board and ask, what could we be doing differently to address racism, implicit bias, and health inequity? We have heard firsthand tonight how state boards can take action. And I hope you will go forth with these ideas, committed to making your board an example for others. One of the greatest strengths of our Federation of State Medical Boards is the way we invite ideas and best practices and share them with each other. Our network is strong, and we can get better by communicating and collaborating even more. So let us do that once again. Let us work closely together to address this very critical issue. By choosing to be introspective, examining how we go about our work, and being open to change, the regulatory community can make a real and lasting difference as we seek solutions. We here at the FSMB are already discussing follow-up steps, and I assure you, we will be back in touch with more information to share. In the meantime, let me once again thank all of our presenters, starting with our keynote speakers, Mr. Marc Morial and Dr. McClellan, and our panelists, Dr. Aletha Maybank, Dr. Leonard Weather, and Dr. Diane Currie. And of course, our skillful moderator, Dr. Humayun Chaudhry. And a special thank you to you and to our FSMB staff and our online technology vendors for their work in coordinating the details of this event. And it has been a very wonderful event. A full recording of the symposium will be available later this week at the FSMB's website, and we encourage you to share it with others. Finally, I want to thank all of you for joining us tonight. We are grateful that you participated and hope you will join us for other FSMB events in the future. Thank you and have a good evening.